Very excited for today's show. Thanks to Medtronic for helping to sponsor this series. With that, I'm going to hand over to Dr. Aminian to welcome Ricard, and thanks so much to the two of you for being here and for everyone for being on the show.
Thanks, David. Good morning, everybody. Thanks for joining us today. We have an exciting case today, and my good friend and colleague, Dr. Ricard Corcelles, going to present that case, and I hope we're going to have a good discussion with people who joined us. So please turn on your camera if you would like to participate, and I can see you and I can ask your comments about the case. Dr. Corcelles is a professor of surgery at the Cleveland Clinic Lerner College of Medicine, and 6 months ago, he joined us from Abu Dhabi to the main campus. Now he's here sitting in the office right beside me. We are so happy that he's here, and he has a vast experience with the single anastomosis gastric bypass when he was practicing in the Middle East. So he's going to present one of those cases. Ricard, take it over, and we're happy that you're going to be here and you're going to present this case with us.
Thank you, Ali, for your kind words. And yes, absolutely. I'm really happy to be discussing the case with all of you guys. So the case is about the 40-year-old female who came to my clinic quite a while ago, complaining about chronic diarrhea, very severe acid reflux, and vomiting. At the time, first thing we did, we were ordering some blood tests that they did show severe and profound malnutrition. You can see here how her pre-albumin was 0.1 albumin 30 grams per liter. At the same time, blood tests were showing an iron deficiency anemia. You can see the values here, as well as a very low fat soluble vitamin levels, A, D, E, and K. Associated with that, she also presented with zinc and copper deficiencies. Her past medical history was not that relevant, only GERD and gestational diabetes. She was taking esomeprazole, and the most important thing here regarding her past surgical history, in 2010, she had undergone sleeve gastrectomy, and more recently, in 2016, in Dubai, patient had a sleeve gastrectomy revision to a Aminogastric or the OAGB that unfortunately was complicated the first week after the surgery with an anastomotic leak that required, based on the reports that we were able to get a reoperation with multiple washouts and drains placement. Physical examination in my clinic, her body weight was very low, 45 kilograms, BMI under 20, 19. You can see the picture here. Patient had a lower extremities edema. Her hair was shedding. Nails had breathlessness, and overall a very, very poor functional status. So at this point, Ali, I think that I would stop the presentation here and ask the audience what they would do at this time with this patient.
Okay, very good. So that's a true emergency. So we need to do something, otherwise patient can die. So it's a life-threatening condition. So let me ask the audience, Dr. Navarrete, are you on the line? Can you guys, or Professor Himpens? Hi, Jack. Thanks for joining us. So you have a patient with history of bariatric surgery, any type of bariatric surgery, and comes to your clinic with severe malnutrition. What are the next steps for the junior surgeons and fellows and residents who are on the line?
You have to correct that malnutrition to begin with and take it very carefully, because if that patient was operated on in 2016, we're a few years later now, and we have to avoid refeeding syndrome. So we have to take it very easy. And usually, I used to actually do it by enteral feedings, by placement of a gastrostomy, feeding gastrostomy in the remnant. But I must say that nowadays, because we see that frequently, we prefer to do a parenteral feeding. And so I would certainly admit that patient to the hospital or keep her in the hospital and start nutrition. I think that's the first thing to do before any diagnostics or whatever.
Okay, very good. Good points. Dr. Navarrete, do you have any further comments?
No, I completely agree. My video is not working, but I think the micro is working. So I would, yeah, probably try enteral. If I can put a tube on the remnant, as Dr. Hinton said, same thing.
Okay. Very good. Okay, Ricard, go ahead.
Sure. So all of those are very good points. So what we did was as follows. At the beginning, we tried to study the anatomy of this patient, providing he had had at least 3 operations before. We ordered upper GI series as well as an upper GI endoscopy, CT scan. I like to order CT scan in these patients, especially when you don't know exactly her past surgical history. As Dr. Himpens pointed out, and as well, Salva, we consulted nutrition, of course, and endocrinology as well. Just a brief summary here. This is the endoscopy we did in this lady. You can see in your left, I mean, a huge amount of bile content. This is the pouch. And when we pass through the pouch, you see the jejunum, there were several large ulcers. This is the view of the same pouch, a little bit more towards the esophagus. You can see that the anastomosis is very narrow, and on the right side of the screen, you can see the upper GI series and that the configuration and that the contrast, that image doesn't show perfectly, but the contrast filled pretty fast the colon. So it was a very short efferent limb in this case. So in summary, the endoscopy showed, as I said, bile reflux, a severe stenosis of the B2 anastomosis. We at the beginning, we decided to dilate in order to favor a little bit her oral intake and to be able to eat a little bit more consistently, and of course the jejunal ulceration was also seen. As it has been said before, the patient was directly admitted from the clinic to the hospital, from the outpatient clinic to the standard hospital room. We started on TPN, fluids, of course, all the proteins and vitamin replacement, as well as a psychology consultation for hers. I think I'm going to stop now again, and I'm going to.
Okay, very good. So, yeah, I mean, I 100% agree that the patient needs to be admitted in the hospital, and the nutritional problem should be addressed very slowly, cautiously, but continuously, because the risk of refeeding syndrome in these patients. So TPN is a good option. The other option was the placement of the feeding tube through nose at the time of endoscopy. So you dilate that, but sometimes the dilation is not that effective, and the stricture and stenosis is going to come back maybe at the same time. We can place a feeding tube through nose. So those are the options. But regardless, we need to improve the nutritional status. So before moving forward, I have just one question from you, Ricard. So the patient had pure anatomic problem. So why did you do the psychology consult? So she had stenosis, ulcer, malnutrition. Why psych consult?
Well, and the answer is quite easy. That lady had delivered a baby 2 months ago. So that made all her not only nutritional, but also her emotional and psychological status very complicated at that time. You know, she was still breastfeeding the baby. The hospital had several, regulations on that. The lady needed to have some sort of support on and reassurance from that side. No, the indication for admission was clear, but the psychological support, I think, at that time, she needed all the help that we could provide her, I think.
Very good. So let me go to Poland and ask Dr. Rogula. So, Tom, any comments about this case up to here?
Yeah, I'm very sorry. I just joined a second ago. Can you give me just two words of?
So, patient had history of single anastomosis gastric bypass, which we know is a malabsorptive procedure, and came in with the severe malnutrition from the ulcer and stenosis of the anastomosis. And they admitted the patient in the hospital for the TPN. So the next step.
The TPN. I don't know. I think I would manage her conservatively. Make sure she's got nutrition. Maybe some sort of tube feeding for the time being, to make sure she's has enough capacity, nutritional capacity to go through any revisional procedure. But eventually, I think she will probably need some kind of revision, and maybe convert it to gastric bypass with a shorter, with a longer common channel eventually. And I know from some experience, not from Poland, because I don't do this here at all, just following the ASMBS guidelines. But in some places where I work as a consultant, this is not uncommon problem, especially in Middle East and some European countries. So this is a kind of difficult situation. So she had marginal ulcer, right? Also.
Yeah,
Yeah.
marginal ulcer and stenosis. So I'm going to get back to you, Tom. Let me ask Dr. Andalib, who joined us from McGill. I mean, what surgical options? So imagine you improve the nutritional status. What surgical option would you consider for this patient? Are you going to revise the anastomosis or convert it to Roux-en-Y or reverse the gastric bypass, or going to have the single anastomosis configuration but shorter BP limb? So I guess first of all, we're going to go in to see what's going on. What's the afferent limb, what's the efferent limb? But yeah, let me share your thoughts with us.
Good morning, Ali. Good morning, Ricard.
Morning.
Ali, I'm really sorry. Like Tom, I joined in a little bit later, but I just got the snippet that you gave Tom. Based on that, if this ulcer is a recurrent ulcer or is like a non-healing ulcer that has caused significant malnutrition in this patient, that eventually you're going to go for a revision. The only revision I would do, I would not stay with the same process. I did not hear whether the cause of the ulcer was bile reflux. I'm assuming that. I don't know if the patient was a smoker or not, but granted that this is a non-healing ulcer in a compliant patient, otherwise, I would not stay with the same procedure. I would change it. Certainly, if the patient is a heavy smoker, obviously Roux-en-Y gastric bypass is also going to be problematic. But the revision for me of this mini gastric bypass will be probably to a Roux-en-Y gastric bypass. Obviously, depending on the other parameters of the patient, I may consider limb lengths in terms of which limb needs to be what. But with the information I have right now, this is what I would do. I certainly wouldn't stay with the same procedure.
Okay, very good. Let me ask Professor Hempens to share his thought about this case at this stage. Jack?
I agree with what I just heard. I think once a patient is sufficiently nourished, you can take her to the OR and convert that, I think, poorly executed mini bypass or single anastomosis into a regular Roux-en-Y, which means that you need to do a resection of the pouch. Don't forget that those mini bypass pouches are too long compared to what we do with the Roux-en-Y gastric bypass. And also in terms of limb lengths, just go ahead and do a regular. I think that convert is pretty simple to do usually, and the outcomes are, I would say, great in about 90% of the cases at least.
Okay, yeah, very good. Good comment. So I think, yeah, first of all, we're going to go and explore to see what's going on. we're going to measure the length of the common channel, the afferent limb, and then based on that, we're going to decide what to do. So let me see if Dr. Rosenthal is available to make comment. Raul, are you around?
I'm available. Just finished exercising, so this is my time. So good morning. For the juniors, surgery at this point is a no-no because the patient is malnourished, so you're going to get in trouble post-op. Agreed 100% with everything that was said. One thing that hasn't been said, and I think it's very important, is try to get the operative reports. This patient had 3 operations. What might look like in the EGD and upper GI as a mini bypass, you can find so many other things when you get in there. Because unfortunately, we bariatric surgeons mess around with limbs, et cetera, et cetera. And you know, this comes as no surprise. A leak is a leak, but the malnutrition and all that, most likely this patient has a afferent limb that is longer than 200 centimeters. In the bariatric literature, the only, or one of the very few prospective randomized control studies, level 1 evidence, is the paper from Robert and the Lancet comparing gastric bypass with OAGB. And if you look at the long-term results, you will see that OAGB has malnutrition, has ulcers, has bile reflux gastritis. So everything that was said, I agree. Put the patient on Questran, put the patient on PPI, and try to give him good nutrition. I think we're months away from a revision. Thank you for asking.
Very good. Good thoughts. Okay, Ricard, we can move forward.
So she was certainly admitted. She spent 6 weeks on TPN in-house. So the enteral feeding was not an option. And the reason why it was not an option was because, as Dr. Rosenthal said, so we were able to capture the CD of the operation, the latest operation, unfortunately, the one that was treated the leak after the mini gastric bypass was done. And I saw there was a severe 4-quadrant peritonitis. So I knew that there would be a lot of additions, that potentially would be a lot of additions. That's why we decided just to keep her on TPN and all the oral supplementation that we could. Okay. So at this point, I think that we will ask the audience, and it's been commented by some of you, what were the options, no? And we thought about a revision from OAGB to a Roux-en-Y, a revision, a laparoscopic enteral access. I just commented why I decided not to do that. Mini reversal and no surgery, just leave her on home TPN.
Okay, I think we discussed that. So you improve the nutritional status, and then it's time to go to the OR because that may come back, and that can be a life-threatening condition for a patient.
So what we did, that's, I don't know, can you see the image?
Yes, we can see the image.
So that's a short video about what we did in the operation. Thanks God there were no that many additions, regardless of the video we said we saw before. So as Dr. Rosenthal said, so the efferent loom, the common channel, potential common channel was very short. It was less than a meter. The first thing that we did was exactly to measure all the length of the whole small bowel. I think that Ali also mentioned that, very important. That's the first step that we do when we revise those patients and we convert them from a OAGB to a Roux-en-Y. So once we exactly knew how was the configuration of the limbs, we started with the dissection. First of all, we tried to get access to the posterior part of the stomach. In that case, we like to use the Goldfinger. It gives you access sometimes to a very narrow anatomical planes. So that's going to be, as has been commented before, what we do is once the posterior dissection is completed, we dissect and divide the pouch to create a small, tiny pouch. Of course, that's been done. That's a very short video with endoscopic surveillance in to be sure that the pouch is very little. In this case, we divided the attachments with the remnant stomach using also an endostapler. So you can see how the previous OHGB anastomosis is being completely freed, and next step of the operation was to restore the continuity of the small bowel and then continue and complete with the Roux-en-Y normal and standard gastric bypass. So sometimes you can avoid these anastomosis, this third anastomosis, if the afferent lymph is very short, but in this case, as you can see, it was not a possibility. So with this, I just wanted to point out, we in Abu Dhabi, we had substantial experience on these cases. Unfortunately, we saw several complications from the mini gastric bypass. That's why my probably view is a little bit biased. So this is the first and probably the largest series ever published on revision cases, including almost 20 cases. I know that now so far the series are almost about 40 patients. Finally, well, the potential risk of and the pathophysiology of the chronic bile reflux is although it's a physiological phenomenon, when that is on excess, and this is been shown in the animal model and in some case series, that the risk of development of intestinal metaplasia and risk for cancer is there. So that is always important to remember. Finally, and then I will open. Well, I'll let you, Ali, open the forum for comments. So those are my humble suggestions, and after my experience with the mini. So I think that all these patients need endoscopic follow-up, and unfortunately, in my experience, very little of them have endoscopic surveillance after the mini gastric bypass is done. I think that some technical mistakes need to be avoided because they can be fatal for the patients. They can be a disaster for the patients. If you do a mini gastric bypass with a short pouch, that can be a disaster for them. So my recommendation: large pouches, measure the whole small bowel, and of course close the pseudo-Peterson defect if it's possible. I think that with all of this, I will finish my presentation here.
Okay, very good. Thanks, Ricard. Interesting case. So just before having the audience comments or questions about the case, I have one question for you. So before taking a patient to the OR, you consented the patient for what procedure? For the reversal or revision or conversion or what? Or you explain the patient all the options?
Well, a reversal to a normal anatomy was not an option, in my opinion. On hers, who had gestational diabetes, I think that the most reasonable thought was to do a conversion to a Roux-en-Y gastric bypass with a short BP limb and be sure that she will be enough nourished and be able to thrive. No, but those were the two options that we discussed with her. And I think that the Roux-en-Y was probably the best in my opinion.
Okay, very good. I usually have a frank discussion with the patient, and sometimes tell the patient it's going to be intra-op decision based on what we find, because we don't know what's going on. Let me ask Dr. Navarrete. Sal, any comments about this case?
No, the only thing I would point about the enteral axis, in this case in particular, there was, the defunctionalized loop was so long. I would try to start enteral feedings if I can. I mean, surgical enteral feedings, either through the remnant or doing a lap J, because that's gonna improve the trophic effect of the tube feeds on that defunctionalized loop of bowel. So when you convert this patient, they're gonna do better quicker than if you just do TPN and then convert right away, because that defunctionalized loop of bowel won't start working immediately. It's the same when we prepare the patient to convert from those distal bypasses that, we put a lap J tube first, let them recover nutritionally, and then you convert to a shorter version of the bypass, I think. And then in terms of the technical aspect of the one anastomosis gastric bypass, we have a little bit of experience with that. And as Ricard said, the pouch needs to be longer than usual. And it's definitely a surgical option. It came out because it was easier, right? It's one less anastomosis, one less mesenteric defect. But, you know, it has some problems with bile reflux. The patients can be malnourished if you don't count the whole bowel, etc. But yeah, that's what I would do.
Yeah, I mean, this one was poorly constructed single anastomosis gastric bypass. So it was poorly constructed, complicated with leak, and then in long run was complicated with the ulcer and the stricture. So if it was constructed in a correct way and patient didn't have those stricture or ulcer, that was not the outcome. And we know that there is no perfect operation. So all of our operations have complications. So let me ask Dr. Garon, Dan, thanks for joining us from Duke. Any comments about this case?
Good morning, Ali. Good morning, Ricard, and everybody here. I think the management is pretty much what we do at our institution. We tend to start the patients on TPN early. We do some nutritional follow-ups. We used to do the CONAT score system to make sure that we don't rely that much only on albumin. We tend to wait at least 3 months to kind of recover this patient and then go to the OR and construct the anatomy as they indicated, a conversion to a Roux-en-Y gastric bypass. The only theoretical thing that we always discuss in our meetings is whether we should do some sort of truncal to avoid any future problems with the anastomosis. Because even though the small pouch, as was stressed by Ricard, is one of the ways to preserve it, she demonstrated that she had several ulcers and maybe strictures. So that is the only thing that I would at least discuss with my colleagues. We have several of these cases. As you know, the mini gastric bypass was started in our hospital in Durham, but one of the the leading authors of this technique. So we see quite a bit of this conversion, but I think the management is very good. And I think the psychological aspect of this, it was very important, not only for the pregnancy, but the fact that it's going to undergo a conversion and all those fears of weight gain and other complications was key in the management of this case.
Very good. Thank you, Dan. Let me ask Dr. Himpens. Jack, any comments about the case? How would you manage this case? Anything different?
I think it was handled pretty well, but I would like to make a few short comments. First, it's in my practice, when we perform one anastomosis gastric bypass, we just limit the afferent limb to 150 centimeters without measuring the entire bowel. And I think as long as you stay to 150 or less as an afferent limb, I think you're pretty much safe. Second, the enteral feedings through gastrostomy or through the afferent limb, don't forget you have a bilirubin 2 reconstruction, so it's very poorly tolerated by the patient when you get those tube feedings that pass at the level of the anastomosis, which is quite different from the Roux-en-Y reconstruction. And then finally, why would anyone do a mini gastric bypass? Well, I'll tell you why. Because I think that's the only procedure that on the long term does not cause pain. And we just reviewed Roux-en-Y gastric bypasses we did at least 10 years ago. And we have about 10% of patients with unexplained pain. And that's something we don't see in the mini or single anastomosis gastric bypass. So very briefly, these were my comments.
Yeah, very good point. So the pain is important issue, and probably that's one of the advantages of the single anastomosis gastric bypass compared to the Roux-en-Y. Roux-en-Y has other advantages, but the pain, as Dr. Himpens mentioned about between 5–10% of patients after gastric bypass in long term develop this chronic abdominal pain without having any identifiable anatomic problem, and we don't know what to do with those patients, probably because of the effect of the Roux, it's called Roux syndrome or something like that. But since we don't have that configuration in mini-gastric bypass, it seems like that chronic type pain is less frequent after mini-gastric bypass. And the RCT that Dr. Rosenthal mentioned, if you look at those, the data in the table, one of the table in that RCT, every single complication was comparable or more common in the mini-gastric bypass, except the abdominal pain. The chronic abdominal pain was more common in the Roux-en-Y than the single anastomosis gastric bypass. That's one advantage of this. Okay, let me have few final comments. Amin, do you have any further comments, questions about this case?
No, really, everything was said. I completely agree with. I mean, the points are in these patients, you don't need to rush. You have the time. Optimize the situation, plan for success. Rushing the patient for a conversion to something else that also has complications as well is not the right thing. We need to get it right. Optimize the patient, plan well, and plan for success. But I agree with all the comments that were made.
Very good, thanks. Tom, Dr. Regula, any final thoughts?
I also agree. I think that that's very reasonable approach to the difficult situation that I actually saw one day in the other hospital, and I saw the actual acute leak from the mini-gastric bypass that looked like a stream of bile coming out all the time through the hole at the anastomosis. So it looked pretty severe, and we had to convert it acutely. Yeah, leaks are pretty bad from the mini-gastric bypass. Now, another comment a little bit aside from the case is, gastric bypass surgeons like myself and probably you, Ali, are probably asking ourselves, maybe it's time to check and see if this is better operation, mini-gastric bypass. Honestly, I am still not convinced. Even maybe there is a little bit less pain, maybe there is a little bit longer, better outcomes from this, but I didn't find a good reason to do mini-gastric bypass as for now.
Yeah, very good. Thanks, Tom. Yeah, as I mentioned, I mean, we don't have perfect operation. All of our operations have advantages and disadvantages, and we should have individualized approach and match good operation with our patient. So let me have Dr. Rosenthal to make the final comment. Raul.
Ali, thank you so much. All I want to say is that it is so funny how we bariatric surgeons think and work. We don't do sleeve because of reflux. We don't now we don't do bypass because of pain. Someone writes or reads a paper and suddenly the whole world is upside down and we're going a different direction. This operation was banned in America because of what you're seeing here now. Malnutrition, malabsorption, severe long-term complications. And unfortunately, when you put it in hands of surgeons that all they care is about weight loss and remission of diabetes, this is what's going to happen. And we're going to pay a big price as bariatric surgeons worldwide because we're going to deal with this kind of very, very serious long-term complications. So I think that everything that was said was okay. And I wish everyone a happy, a very good weekend. Thank you for allowing me to make comments, Ali.
Very good, thank you. Let me see.
And congratulations on your most recent papers that are really being fantastic, phenomenal.
Thanks so much, Raul. So let me ask Dr. Mohammed Jamal. I saw his face. Mohammed, are you available? He is joining us from Kuwait.
Yes, I'm joining you from Kuwait. You can see the desert behind me. So we are camping today in the desert. It's a holiday. But I agree. We published our revision of the sleeve gastrectomy to the anastomosis gastric bypass back we started doing those revisions from 2014 to 2019, and we published 65 cases of those revisions. Yes, when you when you get complications from those surgeries, they are really bad complications in terms of the malnutrition and the bile reflux. It's true that you, especially when you revise a sleeve gastrectomy to an anastomosis gastric bypass, you get a better result than the raw gastric bypass. But when you get the complications, they are really bad complications. So we are reducing our numbers in those surgeries, and we are we are doing them in a much less numbers than when we started doing them. We were keen in exploring the anastomosis gastric bypass, but we are starting to reduce those surgeries and being more, as you just said, we need to be more, our approach should be more individualized. And we should tell the patients that perhaps if you develop complications, such as malnutrition or bile reflux, in the future, we might do a raw gastric bypass for you. The problem in the Middle East, and Ricard might know, that patients really like to choose their surgeries. It's difficult. It's not that the insurance companies are going to pay for them. They are cash payers, and they are very adamant about the surgery that they want. So it's sometimes difficult to explain and consult those patients.
Very good. Good comments. Thanks so much, Mohammed. So Ricard, final comment?
No, I think my final comments are what I expressed in my slide. I think that if a mini gastric bypass is not very well constructed, I think that the price that the patient pays is really high. On the contrary, the reason why, if the pouch is long, if the distribution of the limbs is not probably accurate, whatever, I mean, the patient, the consequences for the patients are not that bad. So again, I think the only thing that the mini has is the name. I think that is a good metabolic operation if it's done, I think, following the standards. But if it's not well build the anatomy of the operation, I mean, the patient can end in a very, very complicated situation. And I think that would be all. Okay, thank you again for the opportunity.
Okay, thanks everybody for joining us all around the world. Have a great weekend. That was a very good discussion.
Thank you
so much,
Thank
Ali.
you, everybody.
Thanks everyone for joining us. We'll be right back here Friday, February 11th, because as a reminder, we do not meet the first Friday of the month. We go through every Friday except the first Friday. And next week's going to be from the hernia group. Dr. Pietro will be moderating a talk about soft tissue coverage after abdominal wall reconstruction. So thanks for joining us. We'll see you in 2 weeks.